Lobar intracerebral hemorrhage is a type of intracerebral hemorrhage based on its location in the brain's peripheral cerebral hemispheres. In comparison to the deep intracerebral hemorrhages that involve the deep gray nuclei or the brainstem, lobar hemorrhages are not related to hypertension and are more likely due to trauma or cerebral amyloids. This type of hemorrhage makes up for about 3.9% of acute strokes and around 35% of intracerebral hemorrhaging. This can majorly affect elderly patients due to the fact that cerebral amyloid angiopathy is a major risk factor, making up about 20% of the lobar hemorrhaging. This hemorrhaging can also still affect younger patients. In these cases, there is typically underlying condition like a lesion to the brain or cerebral arteriovenous malfunction. Some possible symptoms of lobar intracerebral hemorrhage may include some of the following. The most common type of symptom is headache and vomiting during the initial presentation. A decrease in consciousness is also an early symptom. Later symptoms can include seizures and loss of reactivity if the hemorrhage is not taken care of. Now for imaging, CT is the first modality that will be used for evaluating suspected lobar hemorrhage. For CT, a non-contrasted exam will be performed to help visualize and demonstrate if there are any hyperdense collection of blood within the lobes of the brain. This is visualized to the left with our CT image demonstrating the lobar hemorrhage. A CTA angiography, also known as a CTA, is becoming a part of the initial workup for any type of hemorrhaging and/or strokes. This not only allows us to assess any underlying conditions like arteriovenous malformation and aneurysm diseases, but also shows the presence of any ongoing bleed. CT perfusion can also be used to evaluate any hematoma expansion or ongoing bleeding as well. MRI is used to follow up if there are any concerns that the bleeding is from underlying vascular malformations or neoplasms. In the case of lobar hemorrhages, there will be multiple small areas of susceptible induced signal dropout that can be evident on granulate echo, GRE, or susceptible weighted sequences, SWI. Our MRI images is of an axial T2 on the right, locating the lobar hemorrhage. The treatment plan is the same as any other cerebral hemorrhage, attempting to control blood pressure to reduce the risk of any further hemorrhaging. The attempt to reverse any anticoagulation or coagulopathy will be done, as well as the management to reduce any raised cranial pressure built up. Surgical removal of the hemorrhage can be done, but this is based off the size and location of the hematoma. The lobar hemorrhage has shown evidence that minimally invasive removal procedures have shown improvement within 24 hours of presentation. Following the treatment, if the hemorrhage was trauma-induced, the patient may be monitored to ensure there's no ongoing bleeding or symptoms. As for lobar hemorrhages caused by underlying conditions, they will continue to monitor their condition and follow up with their primary team as routine.